Hello, everyone, and welcome to another episode of Let's Talk Hereditary. We have Dr. Matt Khalidi today with us, and we're going to talk about hereditary non-polyposis colorectal cancer syndromes. Dr. Khalidi, thank you for being with us today.
Thank you, Mo.
All right, we wanted to talk a little bit today about familial colorectal cancer and non-polyposis phenotype when it comes to colorectal cancer. So do you mind just telling us, in general, what is familial colorectal cancer and what are the hereditary non-polyposis colorectal syndromes?
Sure. So familial colorectal cancer is kind of a broad definition. It just means that basically colorectal cancer runs in your family. It's kind of a mixed group. There's no clear definition, but it's essentially people in your family have colorectal cancer. You can have a first-degree relative, increases your risk. Having second and third-degree relatives don't necessarily increase your risk as much, but it does make you think about cancer running in your family. If you have more than one first-degree relative, that increases your risk as well. So it's basically colorectal cancer running in your family without a well-defined or known gene mutation that is responsible for causing that. So if you look at the general population, about 1 in 20 people, or 5%, will develop colorectal cancer through their lifetime. If you have a first-degree relative, which means direct relative, mom, dad, brothers, sisters, or your children, anybody who has a first-degree relative who has a colorectal cancer, they have about a 10% chance of having an increased risk. And if you have two first-degree relatives, they're about 20%. So it goes up a little bit more with the more relatives that you have involved.
In the beginning and before genetic testing, there was a group of disorders grouped together as hereditary non-polyposis based on their phenotype. And now when genetic testing has become available, we identified Lynch syndrome. Were there any other syndromes or disorders just grouped under the non-polyposis as well?
So the non-polyposis, essentially what we knew of was called hereditary non-polyposis colorectal cancer, HNPCC, which now has been further characterized as Lynch syndrome by genetic variation, documented genetic variation, because we know the cause of Lynch syndrome. We talked about this in another episode, but if you met clinical criteria for Lynch syndrome, or Amsterdam criteria, which is people that were, which defines HNPCC, but you didn't have a germline deficiency, then you're considered familial colorectal cancer type X, which was, again, this kind of nebulous area that we're not quite sure what causes everything, but we do know that you have an increased risk of colorectal cancer compared to the general population, but not nearly as high as Lynch syndrome. So it gets a little confusing, but if you're Amsterdam criteria that's not Lynch syndrome, or in microsatellite stable, then those people are familial colorectal cancer type X.
And what we just want people to know is if you're labeled under any of those syndromes, what that means is you're at an increased risk of colorectal cancer more than the normal population. And we just want you to be seen by a specialist that at least knows how to take care of you over time. There's another disorder that comes across mind when you think of Lynch syndrome, which is CMMRD. Do you mind just telling us what does it mean and what does it stand for and how can someone be diagnosed with it?
Sure. CMMRD is constitutional mismatch repair deficiency. Lynch syndrome is caused by a genetic variant in one of the mismatch repair genes. And everybody's born with one copy from mom and one copy from dad. And people with Lynch syndrome have one copy gone, and the other copy is functional and works up until whenever it dies out. And that may be at age 20, it could be at age 40. Average is probably around in the 40s. So you always have one functional copy that works. When that one kind of ends up not working anymore, then that's when you start getting mismatch repairs not getting repaired, and you'll have development of abnormal cells and then eventually cancers. That's why the age of cancer in Lynch syndrome or colorectal cancer is in the 40s as opposed to the 60s or 70s. Now, there are rare circumstances where someone is born without either functional copy of a mismatch repair gene, and that's when you have both losses. And that's constitutional mismatch repair gene deficiency. And those unfortunate children have cancers at a young age and get multiple types of cancers. The spectrum's a little bit different. Very common are brain cancers, particularly gliomas. And then people will get colorectal cancers as well as some blood-borne malignancies such as non-Hodgkin's lymphoma.
Are there any different cancers that could present in CMMRD different than the Lynch syndrome?
Well, as I say, glioma is you can get glioma in Lynch syndrome, but it's much less common. And then non-Hodgkin's lymphoma, you don't really see in Lynch syndrome.
Okay. We talked about CMMRD and how that intensifies your risks for cancer a little bit, but then I want to talk a little bit about HNPCC without a genetic diagnosis. So you're a patient that meets Amsterdam criteria, you have a family history of colorectal cancer and endometrial cancer, you got sent to see a genetic counselor, got your genetic testing report, and it says that it's negative and you don't have a Lynch syndrome diagnosis. How do you take care of those patients?
So those are people that are Amsterdam criteria, but germline negative, correct?
Correct.
So that's unique. That would actually kind of fall into the phase of the familial colorectal cancer type X, in that they have an increased risk of cancer, about 5 times fold of the general population, but not nearly as high as Lynch syndrome. Those people also have their colorectal cancers develop at a later age, so in their 50s rather than the 40s for Lynch syndrome. So the big thing for them is that you get colonoscopy at an earlier phase, more at the age of 40, or 10 years younger than the earliest cancer in your family. So if someone in your family had cancer at 45, you would start your first colonoscopy at 35. If they're older than that, or older than 50, then you get a cancer, your first colonoscopy at 40. Then instead of scoping every 1 to 2 years like we would in Lynch syndrome, they get scoped every 5 years, as long as that's okay, as long as the first scope doesn't show anything. Then the other thing with familial type X is they don't necessarily have increased risk for extracolonic cancers. Colorectal is really the big thing, so they don't need to have endometrial screening or other types of screening.
When we talk about Lynch syndrome, also there's multiple mutations. Do you change your screening or your follow-up based on mutation, or all Lynch syndrome patients got followed up the same?
So that's a great point. I think some of this is in flux. There are 4 main genes that cause Lynch syndrome. They're the most common. So MLH1 and MSH2 are the main genes that are mutated. And those are the more common ones. But then there's also MSH6 and PMS2. There is some more information and data coming out that PMS2 and MSH6 might not have as much penetrance, and the phenotype is a little less, meaning you might have a later onset of cancers, and the overall risk of cancer up to age 70 is a little bit lower as well. So some people are starting to think about, do we need to screen these people as frequently, and do we need to do it as early? And we haven't changed that just yet, but I wouldn't be surprised if down the road in the very near future, as things are a little more characterized, we'll start doing a little less screening, particularly PMS2 patients who are at a lower age, and their risk of cancer is probably only about 10 to 15% of colorectal and endometrial cancer compared to the 40 to 60% of others.
If you're a family member that was diagnosed with a pathogenic variant, what is the age that you recommend genetic testing for the kids or the little adults in the family? So
cancers are really, really rare to happen before age 20, and so therefore we don't really do any start screening or any surveillance before age 20. We say usually 18 to 20 because that's when you're legally an adult, and also you have more physical maturity and emotional maturity to make your own decisions and kind of figure out if you want to get tested. I think it's very important to undergo appropriate counseling, so you know what the implications of those test results are going to mean, and you can decide if you want to get tested or not. And then to make decisions about how to respond to those test results. So if you're positive, then we go into our early screening program starting at age 20. If you're getting tested before that doesn't mean a whole lot, or I shouldn't say it doesn't mean a lot, because you're still good to know that information, but you're not going to do anything differently at that point. The other good thing is if you're not positive, so 50-50 chance, right? So if you're not positive, you don't need to get any different screening than the general population, which is a colonoscopy at age 50.
If a patient was diagnosed with Lynch syndrome and they're doing their surveillance colonoscopy every year and they've been followed and they get diagnosed with a right colon cancer, how do we manage those patients?
So first and foremost, we have to treat their cancer. And for colon cancer in general, the primary treatment is surgery, resection of that portion of the colon, and then depending on the stage, we'll end up getting chemotherapy or not. Lynch syndrome is a little bit different because not only is the area where the cancer developed at risk, every single cell in the colon is at risk for also developing cancer because they're all abnormal. So once we know that someone has a cancer, has already developed a cancer, we're going to intervene. The general rule is to do an extended resection instead of just a segmental resection. In someone with the right colon cancer, I would offer them a total colectomy with a connection of the small bowel back to the rectum. So essentially, you're doing a therapeutic resection as well as a prophylactic resection by taking out the rest of the transverse colon and the left colon down to the rectum. We do that because two things. We look at cancer first, and we also look at function. From a cancer standpoint, we know that extending the resection beyond that area and taking out the rest of the colon greatly reduces the risk of getting a subsequent colorectal cancer. There's been multiple studies that looked at just doing segmental resections, and we know that the risk in about 10 years of developing a second cancer is about 15%, and that increases over time to being as high as 60% at 30 to 40 years. So we do know that other people will get more cancer in that space if it's not taken out. The other thing we look at is function. So everyone kind of gets a little bit nervous and say, well, if you take out that much of my colon, will I have bad function? And also, this has been looked at pretty well. And the quality of life, for the most part, has not changed. People do have a little bit more bowel movements after getting a total colectomy versus a segmental colectomy. It's about 2 to 4, 2 bowel movements a day if it's segmental versus 4 if you have a total. And then actually over time, the body accommodates somewhat, and that kind of goes a little bit more towards no difference in bowel function after about 5 years of the surgery. So our general philosophy has been to do more extended resections as long as the patient's healthy and can tolerate the surgery and won't have any other kind of problems with dehydration.
So in general, the concept is extended resection, a total colectomy with an IRA, unless there's any other reason that prevents you from doing that, but that's the standard that we do.
Correct. And the other thing, so oftentimes it's not uncommon to see a situation where someone had surgery done at another institution, and then they find out that they have Lynch syndrome after the fact, and then they get referred to us. There's not a big benefit to doing a second operation to take everything out prophylactically at that point, but anything that's left has to be surveyed every year. And with good surveillance and removal of the polyps before they become cancer, people can do good prophylaxis that way without having to do a total colectomy. However, we do know that there are multiple, in a perfect world that probably would work, but there's multiple challenges with that. Sometimes the prep isn't good. Sometimes the endoscopist may miss something, even if you're an excellent endoscopist, because the polyps are behind a fold or you can't see things. Sometimes the patients are non-compliant. There's a lot of different reasons. So people still develop these interval cancers, meaning before the next scheduled colonoscopy surveillance will be done, a cancer develops in that time. So even in a perfect world, doing endoscopy may not be completely effective. So again, we try to prevent cancers and prevent death from cancer, so we tend to do a little bit more extended resections.
Talking about Lynch syndrome and polyposis a little bit, it comes to my mind a really good paper, and not to confuse the audience, but there was a paper that described the polyp burden in Lynch syndrome. And I know before we had genetic testing and knew anything about pathogenic variants, we used to say Lynch syndrome is a non-polyposis syndrome, and that's how it was described. But there was a good paper that came out of your center that talked about the polyp burden in Lynch syndrome. Do you mind telling us a little bit about that paper and what is the main message you wanted to get out of it?
Sure. So people with Lynch syndrome still develop adenomas, and that's how most of the cancers develop. You have a kind of a basic sequence that goes from normal mucosa to dysplastic cells to kind of abnormal clumps of cells, which is a polyp. Those are adenomas for the most part, and then the adenoma gets more dysplastic changes and become a cancer. So if you can intervene at that time when they're polyps and take them off, you can prevent a lot of cancers. Now, there are some things where there are cancers that develop maybe without a polyp, just within the kind of crypts of the colon, and those may not be preventable, and that's an area of intense study right now and debate. But not everything can be completely avoided. However, even though you have these adenomas, people can get more than one adenoma or multiple adenomas at a time. Now, general, like we're talking about polyposis or FNP, you're talking 20 to hundreds, even thousands of polyps in the colon. So which you don't see in Lynch, but you can see up to 20. I think at our series, 22 was the highest number. So I think the main takeaway from that is just if people have even 10 polyps or 20 polyps, don't forget about Lynch syndrome. It can be a polyposis or it can be actually just Lynch syndrome. In this day and age, when we do more gene panel testing, so instead of just doing targeting testing, say for APC or some of the Lynch genes, we do a broader gene panel that looks at all different types of colorectal cancer risk gene syndromes. And you'll pick that up either way.
And one last question. If I belong to a family that was diagnosed with Lynch syndrome, I got genetic testing and my genetic testing is negative, do my kids have to get genetic testing or not?
No. So if you don't have the mutation of the pathogenic variant, then that ends with you. Now, I guess there's always an outside chance that you would marry somebody who has a potential mutation, but we don't test the kids just for that reason.
All right, Dr. Khalidi, thank you for being with us today. Thank you everyone for listening. And if you have any questions or concerns, please reach out to us or call us for any help.